Okay, path week 4, endocrine. So the endocrine does a lot of stuff, regulates complex functions within the body, all that stuff. And disorders of the endocrine system can be either hypersecretion, hyposecretion, or unresponsive target cells. Or we can have a hormone deficiency, such as in type 1 diabetes, hormone excess, such as in Graves' disease, or hormone resistance, such as in diabetes type 2, where we have the target cells, tissues in general, resisting insulin, trying to shuttle sugar into them. Hypersecretion can come from tumors, autoimmune diseases, excessive stimulation of the gland. Hyposecretion can occur from a failure or congenital absence. Autoimmune destruction, surgical removal, and abnormal signals. And hyporesponsiveness is a tissue or a target issue dysfunction. So I don't think you guys have this slide, but primary and secondary endocrine disorders are going to be based off of where the problem started with. So with primary disorders, this is going to be a problem based off of the gland itself. So let's say type 1 diabetes, we're talking about the diabetes itself, or not diabetes, the pancreas itself not producing insulin. A secondary endocrine disorder is going to occur from some sort of an issue with the pituitary gland, and most often than not, it's going to be coming from like an adenoma or a tumor growing on the pituitary gland itself. The clinical manifestations of both of these are going to look virtually identical, but which hormones associated with that gland being high will tell us whether it's an issue with the gland itself or the pituitary gland. And so with primary endocrine disorders, the gland itself will fail, leading to either an increase or a decrease in hormone production, changes in the levels of circulating hormone, and the blood levels of the corresponding pituitary hormone will be oppositely increased or decreased. I think they'll be oppositely increased. I think so. We'll get to that. Secondary endocrine disorders are going to be where the pituitary gland fails to release its tropic hormone and leads to a secondarily reduces the primary gland's hormone production. So, like in which one was it? Addison's disease, I think it was, where the issue came in that I can't remember actually. We'll come to that. And with this, both blood levels become abnormally low. And both become abnormally low because the end organ, the end gland that we want to have stimulated, for example, let's say secondary hypothyroidism. We're going to have a decrease in pituitary TSH, and with that decrease in TSH, for whatever reason, maybe a tumor on the pituitary gland, we're not only going to have a decrease in TSH, we're also going to have a decrease in the hormones that we hope to have the thyroid release, T3 and T4, but aren't because we don't have enough TSH. So that would be a situation where we have our secondary endocrine disorder leading to a abnormally low level of hormones for both glands. And the pituitary gland is separated up into the posterior and the anterior. The posterior has oxytocin and vasopressin, or ADH, and then the anterior has our growth hormone, TSH, ACTH, prolactin, and FSH and LH. So tropic versus trophic, I don't think you guys have this one either. It's kind of a nifty tidbit for informational purposes only. A tropic hormone is going to be a hormone that controls the function of other endocrine glands, and more often than not, a tropic hormone is going to be released by the anterior pituitary. So all of these guys here are going to be tropic hormones, except for FSH and let's see here. No, those are also, I believe. There's some things here that are a little different. Like TSH would be a tropic hormone. ACTH would be a tropic hormone. Yeah. Okay, and then a trophic hormone is going to be the hormone that actually produces a growth effect in the end tissue that we want to affect. So, for example, in thyroid stimulating hormone, so TSH gets released from the anterior lobe, and then it affects the thyroid, which results in the thyroid releasing T3 and T4. T3 and T4 are not going to result in more hormones being released. They're going to go and directly affect individual tissues. And that's what makes them a trophic hormone. So speaking of the thyroid hormone produces triiodothyronine and thyroxine, otherwise known as T3 and T4, and they are regulated by TSH release, and they regulate the metabolism, and they're required for normal development and growth of tissues, especially in children. So Hashimoto's thyroiditis. This is going to be one of the more common, if not the most common, thyroid-specific hypothyroid issue in the U.S. And a surprising number of people actually have this condition in the U.S. And it will increase in prevalence with age. Sometimes it can even be considered a sort of part of the aging process, in that we have a gradual thyroid failure over time, and there may or there may not be a goiter formation. It comes from a combination of genetic susceptibility and exposure to environmental factors. So, for whatever reason, we have autoimmune, and this is a primary acquired disease, and focus on primary. So it's a primary issue, which means the gland itself has the problem. This is not coming from the pituitary gland. So here we have the autoimmune infiltration, and that causes chronic inflammation of the tissue in the thyroid. Without having enough of the thyroid gland to do its business, we're going to have a decrease in thyroid hormone production, so T3 and T4 are going to go down. And because the endocrine system works on a negative feedback loop, the decreased production of T3 and T4 is going to then result in an increase in pituitary gland TSH production. And the reason why we have an increase in TSH production is because the pituitary gland, the anterior pituitary, is going to activate and release TSH when it's under the impression that there isn't enough T3 or T4 in the body. So we don't have enough T3, T4 in this situation. It's decreasing in production. And so the pituitary is going to ramp up TSH, and it's going to be chronically elevated until we have something telling it, hey, we have enough T3, T4. That increased TSH production is going to put the thyroid gland under stress and work, but it's not going to make the thyroid gland actually produce anything, because the thyroid gland has autoimmune infiltration and inflammation going on, and so we're going to end up having the thyroid gland become fibrotic. So here we can see that we have the pituitary and the hypothalamus right here. We have TSH released by the anterior pituitary, comes down in a normal person, affects the thyroid gland. Thyroid then releases T3, T4 to do its business. It recirculates back up into the blood system, and uses the negative feedback loop to go up and tell the hypothalamus and the pituitary, hey, we have enough in the system, knock it off. In a hypothyroid situation, the pituitary releases T3, T4, gets to the thyroid. There's not much, if any, T3, T4 being produced. There's very little or none at all of T3, T4 in the bloodstream, which means very little is being brought back up to the pituitary gland and the hypothalamus, meaning that or leading to the pituitary gland releasing an even more or an even larger dose of TSH. So some clinical manifestations, some people may have an enlarged thyroid gland or a goiter, some people may not. There's going to be, of course, a decreased metabolic rate. So just your resting metabolic rate is going to be lowered. You're going to have a decreased appetite, but anything you do eat, because there's not much of this natural drive to utilize it in your system, a lot of it's going to be converted as fat, leading to an increase in weight gain. And because T3, T4 are metabolic processes or promote increases in metabolic processes, we're going to have there, with a lack of them, constipation from a decrease in GI motility. So not having enough T3, T4 will cause constipation. We may have an increase in cholesterol and triglycerides, bradycardia because everything's kind of going slowly, lethargy, depression, difficulty concentrating and memory issues, and menstrual irregularities. So everything's going down. Everything's getting slower, getting down-regulated. You may also have an intolerance to cold, receding hairline, dull, blank expression. If you didn't have any energy, I think that's actually kind of how we all look as nursing students. So, thick tongue, mild weight gain. And this is going to be an example of a goiter. So we see here the goiter. This is a massive, which is just simply the hypertrophying of the thyroid gland, I believe it is. And see here this big old goiter. She doesn't look very happy. I don't think I would be happy either. And hypothyroidism may present with hyperthyroid symptoms at first, because the thyroid gland maintains like a storage of about 6 months worth of thyroid hormones, and when they are when the gland is injured or when the gland is under a lot of stress from having a dumping of TSH, we may end up having a wait, hang on, I might be misreading this real quick. Well, there's nothing in the book about this, but so I guess in general we have the gland originally gets injured, and in the process of being injured, we end up with a massive release of the thyroid gland hormones, making it appear as if we have hyperthyroid symptoms. But over time, as the stores of thyroid gland hormones decreases and they're not replaced by more release or more production of T3 and T4, we'd lead then to hypothyroidism. So the urgent form or emergent form of hypothyroidism is going to be myxedema. This is going to be a severe or prolonged hypothyroidism, and people who are with hypothyroidism can progress to this over time. I think it's pretty much a natural sequence of events to lead to this if they are not properly treated with hormone replacement therapy. A lot of times it comes from a precipitating event such as trauma, stress, or drugs. And with that comes a generalized non-pitting edema, which actually is due to the release of, and you guys might cover this in acute, the syndrome of inappropriate ADH release. So basically that means you got an excess of vasopressin or an excess of ADH, same thing. And that's going to tell your body to withhold water, don't urinate it out. and we're going to accumulate this non-pitting edema throughout the body. All this is going to lead to a decrease in level of consciousness because we're talking about super low levels of T3, T4, hypotension, hypothermia, and then may lead to mixed edema coma, which is life-threatening. So for us, we're going to be checking TSH, which should be elevated because it's not getting the negative feedback loop telling it, hey, knock it off. There may be, or there will be, a decrease in free floating T3 and T4, and our goal is to return the patient to a euthyroid state, meaning normal functioning thyroid. They will have to be on lifelong treatment since their thyroid clearly isn't working any longer. And we hope to have their symptoms of hypothyroidism resolve within weeks to months, which is a long time to think about going on without responding super well to treatment, but it takes a while to recover from hypothyroidism. We want to teach the clinical manifestations of mixed edema. So if you start to experience a lot of fluid accumulation, you're not urinating as much, you're noticing hypotension, hypothermia, low blood pressure, or slow heart rate, then we want to have you call in to the doctor. And there may be more follow-up labs and therapeutic monitoring. So Graves' disease, this is also a primary concern here and is the most common form of hyperthyroidism. This is also, like Hashimoto's thyroiditis, this is an autoimmune disorder. We have most of the incidences occurring in their 20s or 30s. And we have, similar to Hashimoto's, autoantibodies or autoantibodies that bind and stimulate TSH receptors in the thyroid. So what's a little bit different about this is that it's the TSH receptors that are affected by the autoimmune disease. So up here we have autoimmune infiltration, and so which leading to chronic inflammation and destruction of the thyroid gland. Down here we've got the autoantibodies bind and stimulate TSH receptors, and so when those receptors are stimulated, they're going to end up releasing a lot of T3 and T4. And then the thyroid gland is going to hypertrophy because, like any kind of a muscle, for example, that is used regularly, it's going to increase in size in order to take care of its business. The pituitary gland then is going to stop production of TSH because we're going to have so much T3 and T4 in the system that the negative feedback loop is going to tell the pituitary and the hypothalamus that they've got a lot of T3 and T4, there's no reason to give out any more TSH. Okay, that's not going to be easy to see. So overall, we have a greater or a higher basal metabolic rate, and they're going to have this massive appetite, but yet they're actually going to end up losing weight. They're also going to develop this exophthalmos, which is like a bulging of the eyes. They're going to have, unlike in Hashimoto's, we're going to develop diarrhea, and in Hashimoto's, remember, it was constipation. They can have heat intolerance, diaphoresis, which is just massive sweating, irritability, insomnia, tremor and palpitations, inability to concentrate, which goes for both this and Hashimoto's, and then either amenorrhea or scant menses. Let's see, blah, blah, blah. Okay. And then here's a couple good images to show exophthalmos. Both of these are exophthalmos. Those aren't accurate. And the palpebral fissure is going to be the distance between the eyelids, both horizontally and vertically. Most of the time they think about it as being horizontal, but from a little bit of reading I did, it seems to be that they measure both horizontal and vertical. So the emergent form of hyperthyroidism is going to be thyroid storm, or otherwise known as thyrotoxicosis. And this is going to be a massive acute release of excess thyroid hormone, and normally comes from some sort of a precipitating event, such as stress, trauma, or thyroid manipulation. I think the most common are surgery, trauma, and infection, leading to thyroid toxicosis. They're going to have a super high temperature. Their heart rate's going to be racing. They may end up having arrhythmias and CHF, just from how hard the heart is having to work. They will not be able to hold still, and they'll be very irritated. They may even be progress to a psychosis, and this is very life-threatening if it's not treated properly. So again, we're going to be testing for TSH, T4, and T3, and these measurements are going to be opposite of what we had for Hashimoto's. So TSH is going to be down because we have so much T3, T4 that the negative feedback loop is going to tell the pituitary and hypothalamus to stop making TSH. And of course, because this is hyperthyroidism, we're going to have an increase in T3, T4. We may have them have a radioactive iodine treatment to destroy the thyroid gland, and that will lead then to hypothyroidism, which will then require lifelong thyroid hormone to act as their thyroid gland. If there are tumors, we may need to have surgical removal of those tumors, and we need to explain to them when to seek medical attention or call their primary care doctor, based off of the concerns for thyrotoxicosis, or once we irradiate their thyroid gland, then about myxedema. Okay, the adrenal glands. So these little doohickeys sit on top of the kidneys. They're divided up into two. I thought it was always three. I don't know why. Two layers. So the cortex is not at the core, ironically, and the medulla is. The medulla gives out epinephrine and norepinephrine, while the cortex gives off all of the hormones. So we got like the sex steroids, testosterone, estrogen. No, not estrogen. I'm lying. Like testosterone, aldosterone is going to be our mineralocorticoid, and cortisol is going to be our glucocorticoid. So we have here, we have the corticotropin releasing hormone, which will tell the pituitary gland to release adrenocorticotropic hormone, which signals the adrenal cortex to release cortisol. Cortisol will then do its little negative feedback loop to both the pituitary gland and to the hypothalamus, saying, hey, I'm here, you don't need to keep on sending signals to get more of me out. So that's how it should work in general. So with Addison's disease, this is going to be a primary condition, meaning that it's just a problem of the adrenal cortex itself. Again, this is going to be involving either an autoimmune issue or an infectious issue, etiology, or it could be idiopathic. And we're going to have a hyposecretion of gluco and mineralocorticoids, but we're mostly concerned with the decreased production of cortisol. Though there will also be a decreased production of, say, aldosterone, maybe testosterone. Okay. And when it comes to the pathophysiology, okay, there's that. So we have an atrophy of the gland. Blah, blah, blah. So the disease will manifest itself when 90% of the adrenal gland is destroyed. That one's important to remember, as is this one. 80% of the cases have an autoimmune origin, and 20% of them result from infection. So of all the cases of Addison's disease, of adrenocorticotropic insufficiency, 80% come from an autoimmune issue, 20% come from an infection issue. Some of the classic manifestations we're looking at are this bronze pigmentation of the skin because of the impact to the other hormones that have to do with secondary sex characteristics. We may see changes in distribution of body hair. So, for example, in women, they may get this fancy little thin mustache. Because cortisol is used and is important for gluconeogenesis, we may experience hypoglycemia without it. May experience postural hypotension, weight loss, GI disturbances, weakness. Let's see here. All right, so diagnosis. So we're going to check cortisol levels in the blood, and of course they're going to be decreased. If it's a primary issue, we're going to see that ACTH is high. If we check the plasma cortisol levels, which if we have some form of insufficiency, then the plasma levels are going to be low. But then if we check the ACTH levels and they're high, if the ACTH levels are then low, then that may mean that we don't have a primary adrenal insufficiency or adrenocortical insufficiency. That could mean that we actually have an issue of a secondary insufficiency that came from a tumor on the pituitary gland. So if we, let's walk that through a little bit. So we have a pituitary gland that has a tumor, and it's not producing enough ACTH. ACTH, minimal amounts are going to reach then the adrenal cortex, telling it to produce minimal, if any, cortisol. If that adrenal gland had enough stimulation from ACTH, it would work just fine. So the issue comes in that it's a pituitary gland issue, if it's a secondary issue. So that's kind of where we get with the ACTH measurements. We check both the primary organs or primary glands hormone levels in the blood to see is it producing enough in the first place, and then we check and see what hormone tells it to produce that hormone, and that will tell us whether it's a primary or a secondary issue. That may have been the most confusing thing possible for me to say, but now reach out if you're so confused about that. And that's kind of what this ACTH provocation test is. So if we do this provocation test and they fail to produce cortisol by putting ACTH synthetically into the body, then that means it's a primary issue. But if we give them ACTH and they do produce their cortisol and other hormones, then that means that the issue is not lying with the adrenal cortex. The issue is that we have something wrong with the pituitary gland, since it's not properly giving signals to the adrenal cortex to release hormones. Hopefully that was a little bit less confusing and rambly. All right, moving on. Nursing implications for patient education. They're going to have to be on lifelong hormone replacement therapy, because at a physiologic dosing, not pharmacologic dosing. So like pharmacologic would be what we give as a normal dose for someone who's experiencing asthma or an allergic response. A physiologic dosing is meant to mimic how much we would give if a person were to have properly working adrenal glands. We would want to give 2/3 of their dose per day in the AM, so in the morning, and then 1/3 in the evening. If we have a stressful situation, and this is really critical to remember, we want to increase the dose. So if they have an illness, surgery, an injury, or like a really stressful period in their life, we may need to up their dose just to make sure that they can properly compensate for the stress. And then we want to educate them on when to contact their PCP based on clinical manifestations. So if we start to experience more weakness, GI disturbances, weight loss, postural hypotension, any of these things, if they start, after having started treatment, if they start to experience any of that, that means it's time to call the doctor. All right, so Cushing's disease, also known as, no, it's not. I'll get to that. So, Cushing's disease. This is our only mentioned secondary issue, and that comes from a pituitary adenoma, which is a form of tumor on glandular tissue, um, resting on the pituitary gland itself. So, we have this hyperfunctioning, hyper-secreting anterior pituitary that's releasing a ton of ACTH into the blood. And that ton of ACTH is telling the adrenal gland, put out a whole bunch of all your stuff. So mineralocorticoids, glucocorticoids, all the stuff. And so that's how we get this hypercortisolism. Cushing's syndrome is going to be some other reason for hypercortisolism that doesn't have to do with a pituitary adenoma. So maybe there was a bunch of steroid use. Like in bodybuilders, you have to take a whole bunch of steroid use. Or maybe they have, normally you would think the other way around for taking too much actual medical steroids. I can't think of anything else off the top of my head. Something else that's more like a primary issue where the gland itself stops functioning properly and produces a whole lot more cortisol than it should, that would be Cushing's syndrome. So remember that Cushing disease is going to be the secondary one that has to do with the pituitary adenoma. Cushing syndrome is going to be the one where it has to do with something other than a pituitary adenoma. And then to make things even more confusing, don't confuse Cushing's triad with any of these things. I'm not sure if anyone's ever heard of Cushing's triad. It is nothing to do with cortisol or the adrenal glands. You guys will cover more of it in, I think, seizures. I think that's where you'd find it. Okay, so, or maybe musculoskeletal. That might make more sense. Path of Cushing's disease. So we have the adenomas on the pituitary gland that increases the production of the pituitary ACTH, and the pituitary is then not sensitive to the feedback loop. So no matter how much cortisol or any other adrenal hormone is released, none of the pituitary is going to respond to the negative feedback of those chemicals or hormones being in the blood. So the pituitary hyperstimulates the adrenal cortex, leading to a whole bunch of cortisol in the blood. Okay, that's pretty straightforward. So the classic manifestations that we have for this, for whatever reason, they called it the moon facies. I don't know why it's called that, but it's a round face, it's flushed, it's red, it has extra fluid or fat developed into it. The person's going to have weight gain, so you can think of like, if someone's taking a whole bunch of prednisone, they're going to gain weight from being on that. A lot of it may be water weight. They'll also have fat redistribution to the abdomen, as well as the cervical fat, so what the more like a buffalo hump kind of a thing on the back of the neck. And then the same thing that would happen if you were to put steroid cream onto a spot for too long of a period of time, it would end up thinning the skin and develop purple striae around it, so stretch marks. They're going to have a decrease in muscle mass over time, along with weakness, and then hyperglycemia, because cortisol promotes gluconeogenesis, and it's going to increase our blood pressure. I looked at hypertension, saw blood pressure. It's going to increase our blood sugar, and then the release of aldosterone is going to promote salt retention, leading to hypertension. All right, so for our patient education, we're going to talk about doing labs of them, checking for ACTH, which is going to be both high, as well as the plasma cortisol. So both of these are going to be high, which indicates that it's a secondary hormone or endocrine issue. One of the treatments would be a transsphenoidal hypophysectomy, which is going up into the nose, nasal cavity, through the concha, through the sphenoid cavity, and taking out the tumor or the pituitary. I don't think it'd be the entire pituitary gland. Part of it would be taken off to release or prevent it from making a mess. We could also do a laser ablation of the pituitary gland. I haven't heard much about what the long-term effects are, or how much of how many hormones you'd probably have to take just to maintain the efficiency and the work of the pituitary gland. This sounds like it'd be horrible overall. We can also use pharmacologic agents and would need to afterwards to maintain hormone levels. And then we would need to assess adrenal insufficiency over time, since having hypercortisolism can produce adrenal insufficiency. And then know the clinical manifestations of if your drug regimen after treatment is not effective. Okay, blah, 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 blah. Diabetes. So this is a metabolic disease where the body's inability to produce, or the pancreas is unable to produce any or enough insulin, or is not able to respond to insulin. And then we have these elevated levels of glucose in the blood. I really think they need to change that graphic. So leads to chronic hyperglycemia. And we have type 1 diabetes, type 2 diabetes, pre-diabetes, which is designated as having a fasting blood sugar of between 100 and 125. We can have temporary gestational diabetes, and there are other types of diabetes as well. With type 1 diabetes, this is going to be where we have destruction of the pancreatic beta cells, and the beta cells are the ones that produce insulin. This is an immune-mediated issue, or it could be idiopathic, where we just don't know what the hell is going on. And it's usually diagnosed early in life. So, but regardless of whatever it is, it's pancreatic beta cell destruction. And inadequate, if not no insulin whatsoever being produced. And so the immune system attacks the pancreatic beta cells, leading to insulin deficiency, and glucagon will then be increased in its production by alpha cells, leading to glycogenolysis, which is going to be the breakdown of glycogen, and gluconeogenesis, which is going to come from the products of glycogenolysis, and will then lead to an increase in glucose levels. And this will help to promote a lot of the classic signs and symptoms of diabetes. Really such a bad graphic. So ketoacidosis is going to be one of our main emergencies. This and hypoglycemia are going to be two of our main emergencies with type 1 diabetes. So with ketoacidosis, what goes on here is the body, after a period of time, is going to result, or is going to, resort to lipolysis, which is the breakdown of fats for energy instead of carbohydrates, and they're going to convert it to ketone bodies as energy sources. Ketone bodies are very acidic, and so we're going to end up with this metabolic acidosis. And so we're going to have this super thick blood in our body, and the sugar that accumulates as well in the body, in the bloodstream, is going to promote polyuria, polyphagia, polydipsia. The polyuria is going to be the most important in this regard because that's going to lead to hypovolemia. Because the body's like, wow, we got this bunch of sugar in the blood, we got to get rid of it. And then we can also have acidosis-induced hyperkalemia, because with acidosis, we get potassium to shuttle out of the cells and into the blood. Ketoacidosis can occur with type 2 diabetes, but it's not as common. It's much more common to have issues with the hyperosmolar, hyperglycemic thing that we're going to get to in a second. All right, so prediabetes is going to be where we have impaired fasting glucose tolerance labs, which is going to be measurements of between 100 and 125, as opposed to the normal for fasting, which is 70 to 100. This is going to be intermediate between normal and diabetes type 2, and this represents having a risk factor for developing of diabetes and onset of cardiovascular disease. Type 2 diabetes is going to be where we have insulin resistance. That's the big piece of type 2 diabetes. And there's also going to be some beta cell dysfunction, which can lead to a decrease in insulin. This is the most common form of diabetes, and obesity, being non-Caucasian, female, elderly, and having a sedentary lifestyle are all risk factors for developing type 2 diabetes. So the pancreas releases potentially sufficient secreted insulin into the bloodstream, as well as having enough glucose in the bloodstream, so all that's fine and dandy. The biggest issue is that we have an inability of the muscle to use glucose due to the fact that it resists insulin. And obesity, inheritance, and other factors then would be some of the causes that would lead to the insulin resistance in the first place. That is tiny, 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 tiny print. Okay, so most of that is pretty straightforward though. Okay. The sort of emergency that we can have in type 2 diabetes compared to type 1 is non-ketotic hyperglycemic hyperosmolar coma. I think sometimes it's also called hyperglycemic hyperosmolar syndrome, HHS. Regardless, the idea is that this is not ketonic. So we're talking about a syndrome where the patients are not resorting to using ketones and lipolysis for energy production. But they still do have high levels of sugar in the blood. And their blood is still becoming much thicker because they're urinating out a lot of the sugar that's extra and building up, the 3 Ps, and eventually can lead to coma. This is more common in older adults because a lot of times they don't necessarily recognize, they don't have the same physiologic response mechanisms to indicate that they are hyperglycemic or hypoglycemic. And they can have severe hyperglycemia, like in the 700s, with no or only slight ketosis, but striking dehydration. So they're going to be super dehydrated. And with this, where there's still some insulin in the blood, that's the reason why this is not ketotic. There's still just enough insulin to allow the cells to have just enough sugar to not resort to lipolysis. For screening of diabetes, we're going to screen all adults over the age of 45 every 3 years because of just how common diabetes is. But if they have any risk factors like family family occurrence of diabetes, or if they have risk factors other than genetic inheritance, then they're going to be screened earlier and more frequently. And they will have a diagnosis if they have 2 of any of the following. So a random blood glucose over 200 with signs and symptoms. That part right there is important to remember. A fasting blood glucose is sort of our go-to for diagnosis. And for diagnosis, it has to be over 126. And that's usually after 8 hours. They can also have a plain blood glucose from an oral glucose, after an oral glucose lab, or giving them the 75-gram oral glucose tube, basically. And if their blood sugar is at 200 or more after 2 hours, that would also be an indication. A1C, though, is going to be one of our best indicators of um, diabetes and the trends in diabetes in a patient. And if that's over 6.5, then we got a problem. Come on. What the hell? And this kind of puts it into another way to look at it. A1C, this is a pretty actually good chart to show what A1C is and how it works. So we've got here our little glucose buddies. These are 5 or 6 carbon sugars to indicate glucose. We have here our red blood cells, and we have here our hemoglobin. So glucose, so red blood cells are freely permeable to glucose molecules. So glucose can freely go into, this little guy is meant to look like he's inside, like, having entered right here, inside the glucose, or red blood cell. When they're inside, they will bind irreversibly to hemoglobin to form glycated hemoglobin, or HbA1c, hence the A1C. And because they bind irreversibly, they will remain in the blood cells until the blood cells get recycled. And they have a lifespan of about 120 days. And so measuring the A1C in red blood cells can show us how glucose levels have been in the preceding 2 to 3 months. You should never eat 6.5 donuts. That's just bad. Cool. Okay. Okay, so these are some of the symptoms of diabetes, mellitus stuff. All right, chronic hyperglycemia. We have both macrovascular and microvascular changes or damage. So at the macrovascular level, this is damage to large vessels, which can lead then to cardiovascular disease and peripheral vascular disease and stroke. So this is going to be like atherosclerosis, for example. Whereas microvascular is going to be abnormal thickening of the capillary basement membranes. So that in particular can lead to neuropathies in the feet, blindness from retinopathy in the eyes, and renal failure because of stuff. There's an increased risk of other diseases associated with metabolic syndrome, which is also an important disease, syndrome. But in general, when we have better glucose control, we have fewer complications, not less, fewer. Okay, so chronic hyperglycemia is a part of the metabolic syndrome, which is very strongly correlated with heart disease and early death. So we have things like insulin resistance through diabetes mellitus, glucose intolerance, hypertension, high triglycerides, low HDL cholesterol, and I believe the actual terms that they use are a waistline of greater than 40 inches in men. I don't remember what it is in women. I apologize, ladies. Glucose intolerance gestational. So women can have diabetes temporarily during gestation, and it comes on from hormones. And really, it's just glucose intolerance, insulin resistance. Looks like diabetes type 2, and precipitated by the placental hormones and increased weight. Risk factors for gestational are going to include pre-gestational obesity, a history of gestational diabetes, having previous births that had babies of more than 9 pounds, having a strong family history of diabetes mellitus type 2, and we will do screening for them for anyone who's over 25 years old and for all women who are weeks 24 to 28. That's typically when we're going to see it taking place. So some of the complications, since we've got so much blood sugar going into circulation, which includes into the growing fetus, we can experience stillbirth, macrosomia, which is a large fetus or baby for gestational age, and hypoglycemia. I don't remember exactly why hypoglycemia occurs. I couldn't find that in the book. I believe that occurs from the babies being used to having high levels of blood sugar, and then when it's born, it is basically not able to produce the same quantity of blood sugar, and so it can experience symptoms of hypoglycemia. And then the mother will be at higher risk for type 2 diabetes. Managements we're going to include having a diet that meets the needs of the mother without going into extreme overabundance of calories, promoting exercise, which helps with insulin resistance, checking blood sugar, and producing or providing insulin as needed. Hypoglycemia is also an issue. This can be a medical emergency. People can go into a hypoglycemic coma. They can present with anxiety, sweatiness, hunger, confusion, being just completely disoriented, and can come from several things such as insufficient food, excessive exercise, excessive insulin, or oral hypoglycemics, and can have a very rapid onset. So, I mean, someone goes and does a crazy hard workout and doesn't do anything to replenish the energy that they just used, and a few hours later they are super hypoglycemic and hangry. Or if we're talking about a diabetic patient, then someone who took in a bunch of insulin, not enough sugar, all of a sudden they've crashed. So the treatment goals here are to control blood glucose, prevent acute and chronic complications. We want to have this is a before meals and after meals. I've never heard of these before and I never saw them again. Sugar readings, so before a meal, we want to see sugar readings of 70 to 130. After meals, we want to see a sugar of no more than 180. And we want to educate them on diet and exercise, smoking cessation as a general health promotion thing, how to notice hypoglycemia, which includes also thinking about the pounding or racing heart rate that occurs when you become hypoglycemic. Daily foot care is a big deal because they have neuropathy, pedal neuropathy, which can lead to gangrene and foot ulcers or pedal ulcers if they don't take care of it. And then stress management, because that can help to improve glycemic control and also reduce depression. We also want to talk to them about how to have the right kinds of meals and how to promote a lack of major fluctuations in, especially in diabetes type 2, major fluctuations in blood sugar. And so talk about meal timing, having more meals that are smaller, having the right kinds of composition, not a whole bunch of grains, especially not empty grains, no a lot of sugars. We want to promote a decrease in alcohol use because, one, it's an increase in empty calories, and it can also cause hypoglycemia. So if they have this issue, if this causes in them hypoglycemia, we want to completely just avoid it because it blocks gluconeogenesis. For children, the goals are going to be that we are just going to allow them to have the nutrition they need to promote active growth and development, and we want to avoid any acute and chronic complications. And the big thing here actually with kids is that we want to address psychosocial issues because they're going to feel potentially very different from other kids as part of one of Erickson's stages of psychosocial development, is that they are going to end up feeling poorer about themselves when they notice that they are different than other kids. So that's something we need to address in them. And we also need to address education for children and parents regarding self-care and how to manage their diabetes, just like adults. Okay, so a lot of these are just the same kind of thing. In geriatric populations, though, we need to make sure that we're aware that hypoglycemia can be asymptomatic and be difficult to catch. And so they need to be more proactive in monitoring their blood sugar and knowing what little subtle cues to look out for that indicate that they are hypoglycemic. They do have an increased risk of non-ketotic hyperglycemic hyperosmolar coma because of basically other illnesses acting as comorbidities, allowing them to, or making it so that they are more likely to enter this disease process. Oh, and that's it.